So today our presentation is the New York City Department of Health and Mental Hygiene update, making New York City the epicenter of the end of the epidemic. And I know a lot of folks know our speaker today, but just for staff who are new, who didn't have the wonderful experience of working with Dr. Daskalakis when he was here with us at Mount Sinai on a full-time basis, I'm going to introduce him. So Dr. Demetre Daskalakis is the Assistant Commissioner of the Bureau of HIV Prevention and Control of the New York City Department of Health and Mental Hygiene. He has been a career-long physician activist in the area of HIV treatment and prevention among LGBT people. So please welcome our guest speaker today.
Hi, everybody. It's nice to be home. Everyone at Roosevelt at Mount Sinai West is sitting so far away from me. So if you want to come closer, it's okay. I promise I don't bite. But if you're comfortable with your pizza, don't worry. So thank you very much for having me. I am excited to come and talk to you a little bit about where we're going with a lot of the end of epidemic plans from the perspective of New York City. I will give you a preface and say it may be different after December 1st. So there's some stuff I can talk about and some stuff I'm not going to be able to talk about. So I'm just giving you what we know right now, which is very exciting. But this is an ever-shifting, moving conversation, very dynamic. So please look out on December 1st for a lot of news in every direction, I hope. So that's a little preview. So with that, I'm going to just start off and talk a little bit about this idea of us becoming the epicenter of the end of the epidemic. So this actually comes from 1 year ago when I had the great privilege of being at the Apollo talking on World AIDS Day. I kept hearing everybody calling New York City the epicenter of HIV/AIDS in the U.S. And it was, and historically that's where we are. But our new charge is that we're going to make New York City and New York State the epicenter of the end. And hopefully I will weave some stories together to show you the direction that we're going in. So I start off always by talking a little bit about where this all came from. So really, the end of epidemic conversation is one about New York City and New York State. And one of the important pieces to take away from this presentation is that New York City and New York State are deeply in cahoots over this. We're working very closely together, and it is really one strategy that we're coming up with, and we're just translating the statewide strategy and the citywide strategy into a package that works in both. So when we ask the question, why New York, it really starts from the perspective of a convergence of science with advocacy and government. So it all starts when these gentlemen, who you may recognize as Charles King from Housing Works and Mark Harrington from ACT UP, were arrested in front of the White House. When they were in the Hoosgow, they decided that they would work with New York State to try to create a plan to end the epidemic. So then months and months and months and potentially years of advocacy led to a conversation where this became possible. So the advocacy lands on a fertile ground. And that fertile ground is that there are things that have changed from the science perspective of HIV that makes this a time where this is potentially possible. So when we think about the science, I'm not going to go deeply into studies, but just talk about what the environment is like. So I put this picture up of Tony Fauci. So many of you may recognize him as really the leader in HIV research for in infectious disease research, actually, at the NIH for the entire country. And I remember when we had our very first meeting of the governor's task force to start putting together the blueprint to end the epidemic, Dr. Fauci gave a webinar, and he really wove a story saying that there was great scientific possibility that this advocacy thought that was had in New York State and New York City could actually translate into reality. And so some of the background of that is we have HPTN 052. That's a study that demonstrates if you treat someone living with HIV and get their viral load undetectable, there is a almost 93% reduction in HIV transmission to their HIV negative partner. So treatment appears to be prevention. We've been trying to get people on treatment for a long time, and I'll show you some of the successes and challenges in New York City. We have the START study, which just confirmed what every HIV provider and other person and guidelines author knew, which was that starting people sooner actually resulted in less morbidity and mortality. So this study was stopped because people who started HIV medicines right away didn't die, and they didn't have complications. So looking at that completely separately from the perspective of transmission, just from the perspective of treatment as treatment, it works. And it works so well that there's no reason to hold back. So I'm going to invoke a former leader at New York City, who's now a leader at the CDC, Tom Frieden, who wrote this fabulous paper, I think it was in JAMA if I remember, about treating HIV like every other infection. So we wouldn't hold back on treating a lot of other infections. You have TB, we should probably wait a minute. No, you have TB, let's go. And so I think that HIV now is living in that similar vein. And so this data really supports the guidance and really what providers have been doing in New York for a while. And then there's the entire PrEP story. It is literally a series of studies that somehow have the word PrEP in them, where we can talk forever about the data, but there are data that we can use HIV medications embedded in other services to prevent HIV. So the science says that if you put a bunch of stuff together in an environment that's willing to do it, then maybe what the advocates said in the jailhouse in DC is possible. And so then you have the governor. And so we have advocacy, we have science, and then we have the political will. So June 2014 is a really important time in the history of HIV in New York City and New York State, where the governor announces his intention to make New York State the first jurisdiction to end AIDS. Take that, San Francisco. So the really important piece of this is that the governor said, let's do it. We're going to talk a lot more about that. You've already heard a presentation, I think, from Charles King. I will reinforce a little bit of what he said, but then we'll go deeper in. So the task force was appointed and met for a very short amount of time. I mean, we were going back and forth to Troy every 2 seconds. We got to know Amtrak a bit too well. And we produced a blueprint that I think everybody is pretty proud of. Here is its picture. I'm sure you've seen it several times. There are paper copies that exist in the universe, but really the online version is cooler because it hyperlinks to all the work that we did. The blueprint was presented to the governor April 2014 in front of the LGBT Center downtown, and he accepted it. And so now the work begins from the state perspective, and much of the work going on in New York City was reinforced and then further pushed forward by the fact that this blueprint, which is heavily inspired by the work that we're doing, is something that is a lauded and important document in the state, city, and potentially in the world. So there it is, the convergence. But now I want to step back for one moment and talk a little bit about the fact that one of the reasons that this is possible, that it is possible for New York City and New York State to bend the curve of HIV is we've already done it a couple times. So here's a really important slide. It is the history of the epidemic using surveillance data from 1981 until 2013, 2014 coming soon. So when you look at this, there are a couple of important lessons. So at the beginning of the epidemic, we had an upswing in new AIDS diagnoses and HIV-related deaths. So that's really the beginning of the story. So things were going straight up. You noticed that before there was a decrease in new AIDS-related diagnoses and HIV-related deaths, that bend of that curve happened around 1996, but the numbers started to go down before then, and a lot of people believe that that's because of syringe exchange, just by the way. So that's sort of the first step. So a harm reduction intervention started to bend the curve, and then in 96, antiretroviral therapy as a cocktail was introduced, and those curves bent, and they bent in a really big way. In fact, they crashed down. And then you see a new line that emerges, which is a line of new HIV diagnoses. Well, that's because in about 2001, new HIV diagnoses became reportable to the city. It's not because all of a sudden this line sort of fell out of heaven right here. But what you see is, as fewer people were dying of HIV, as fewer people were getting diagnosed with AIDS, more and more people were living successfully with the virus. So these blue bars represent both a love song to all the work that you're doing in the clinic every day, and also one of the challenges, which is that to help people live successfully, we have to work hard to keep them virally suppressed. Why is that important? Because you'll see that these bars are going up, but this bar is going down. So there's the second bend in the curve. As more and more people are getting news of their HIV diagnoses and are connecting to care and are getting virally suppressed, they transmit HIV infection less frequently. And so what you see is new diagnoses are going down. There is a plateau coming right here. You can see it. So that's what the challenge is. How can we drive this down faster? This line is not coming down because of increased condom use. That's stable. There's no change in condom use. It's a straight line. It's not happening because of PrEP intervention in 2012. Really, PrEP got hot recently from the perspective of people going on meds. So ultimately, I'm showing you this to remind you that New York City is every prevention and treatment study rolled into one and demonstrates that treatment works, prevents HIV complications, AIDS, and deaths, and treatment decreases transmission of HIV infection. We bent the curve once, we bent it twice, and now we've got a third strategy. We're going to bend it the third time with the goal of getting to a much lower number. And so this is how we're supposed to bend the curve. There are 3 pillars to the blueprint, 3 pillars to the plan to end the epidemic. What they say verbatim is identify people with HIV who are undiagnosed, so test more. The second is link and retain persons with HIV to healthcare. Get them on antiretroviral therapy to improve their health and prevent transmission. So that's link, retain, and treat. And the last one is provide pre-exposure prophylaxis to people at risk of HIV to keep them HIV negative. So you should be looking at me and saying 1 and 2 we've been doing the entire time, 3 is new. And I will look back at you and say, our charge is to do 1 and 2 faster and better, and 3, we're not going to wait for 20 years for implementation. We have to make it happen now because we've been given a deadline of 2020 to end the epidemic of HIV in the city. But there's another really important thing I want to focus on when we look at the pillars. So this is what the pillars say, and this is what I think the pillars mean. There's an apocryphal truth that's built into them, which is that this is really an important strategy for us to get LGBTQ youth of color and other men and women who have historically not been served by healthcare into the services that we have. I always step back when I talk about this and say, I had a lot of opportunity in the year since I left you all as a full-time person here to interact with a lot of people around the country, lots of Department of Health, lots of community-based organizations. And one of the things that I've learned is that New York City, New York State is a wonderland, and that we need to have a high amount of gratitude that we have a system here where we can potentially lead people who are at risk or living with HIV to high-quality services. There's a lot of people in the country who have the intention to do this work, but they have nowhere to land anyone. They don't have Medicaid expansion. They don't have PrEP assistance program. Their ADAP has a waiting list. That's not us. So we have the opportunity to create a delivery system and a way to make the potential consumers for HIV treatment and HIV prevention come to what we've got to offer, which honestly is a wonderland compared to everything else that I've seen in the country. So that's really what the apocryphal message is, that we can use HIV testing, HIV treatment, and HIV prevention to leverage our system to actually make it work better, which I think is very exciting. So this is what our aggressive target is. This slide is from Dan O'Connell, who's my partner in crime from the state. And what you'll see is that the goal is to decrease new infections by 2020 to 750. To prove that we mean it, when we did some targets for New York City, we actually based our targets on this number, which then makes it very aggressive for New York City because we're 80% of the epidemic. So we prorated it for 80%. So we have to move pretty quickly to make this happen. But what you'll see is we don't expect to see a lot of change in the first couple of years. It's pretty stable. But then what the charge is with implementation of all the work that we have initiated, one should start seeing this careen down. And so that is really what our charge is. So now what I want to do is look at each of the pillars plus a couple of extra things in terms of what we're doing right now in New York City and how that works in the context of ending the epidemic. And there will definitely be time at the end for some questions and conversation. So here is the story of HIV testing in New York City so far. So this is data from our community health survey. I'm going to talk you through it in about a moment, but I really want to start by talking about how fertile the ground is in New York State to make things happen. So there have been several changes in law in New York State. Consent has been liberalized. You're able to do verbal consent for every kind of HIV test, not just rapid, and not only can you do it in the community, you can also do it in corrections. There is obviously desire to make it even easier to get an HIV test, but we're already starting at a pretty good baseline. When you look at what's going on in the city, you'll see that the paler the color, the more testing has been done. So you'll see that a couple places that have met us with our jurisdictional testing programs, the Bronx, actually appears to be one of the best tested places in the city. And I'll tell you, in the country, and the world. So if you actually look at the percentage of people who are tested for HIV, the Bronx is one of the leaders in the world. So they're amazing. We just had a meeting with the Bronx Knows folks today. They are a force to be reckoned with. Brooklyn looked a bit more red before. It's looking less red now. So more and more people are finding out about their status there. Queens and Staten Island, they're a project. So we definitely are excited to work with them more. And then you'll see Manhattan definitely has areas where we could do better, but you guys are on target and will be more on target with what's going on with New York Knows. So I also step back and talk about what the CDC says about our level of awareness of HIV. On June 26, 2015, the CDC released a report that talked about people aware of their HIV status state by state. New York State, in that, was noted to have 92.9%, almost 93% of their people living with HIV aware of their diagnosis. Okay, who else is like that? Vermont, North Dakota, and Maine. What do we have in common with Vermont, North Dakota, and Maine? Nothing. Exactly. So New York State is a high prevalence state. When you look at California and some of the other jurisdictions out there, they fall at least 4 points below us. So definitely the energy is there and again, fertile ground for HIV testing to make a change. So this is one of our very major pushes from the HIV testing perspective. It's New York Knows. Many of you know about it. Mount Sinai is definitely a part of it. One of your co-chairs is from Mount Sinai Beth Israel, so it's amazing, from Peter Kruger. So we're working with all these jurisdictions to power things up. One of the things that we've done is we've added another pillar to our strategy for New York Knows. So right now, we've added one. Before it was get everyone tested, make it a routine part of healthcare, and connect people who are positive to care. We added PrEP into this as well. So we're blending the story of HIV connection to care and PrEP connection to care to the HIV test. How does that look on the ground? Every borough in my bureau, that sounds weird, every borough has a project officer that works with them on their plans for New York Knows. So Queens Knows, Staten Island Knows, has their own human assigned. That person is also their connection to PrEP technical assistance. So as they're up-powering testing, they're also going to learn better how to make PrEP a piece of the story. They've already are working with really significant strategies to connect people who are positive to care, and we're also going to be helping them with that as well. So here's our details. What are we doing right now in terms of testing? We have embarked on a 5-borough serosurvey to more accurately measure the number of people who are unaware of their HIV diagnosis. So CDC made an estimate. We want a real number based on what we found. We've done the Bronx already. The first part of the serosurvey is done. At least the tests are in. The data is being analyzed. The second part of the serosurvey will launch soon at, drumroll please, Mount Sinai, Beth Israel. And so you guys will be a piece of that story. We will do 5 boroughs. In the past, only 1 borough was done. So we assume we will have a much better estimate of our prevalence as well as the number of people who are unaware of their HIV diagnosis. We are also going to recompete our HIV testing contracts. So right now, when you look at how we pay for testing, we pay test for test. You do a test, you get some money. Well, problem is more and more people in New York are insured, so the pool of people who are able to access testing using that mechanism for free through Department of Health is getting smaller and smaller. So some percentage of our contracts are going to change, and instead we're going to work with big facilities such as this one to try to further leverage the state law and try to get more people tested within the context of healthcare. So that's going to mean redefining and modernizing our strategy for supporting HIV testing throughout the state. We will also reinvigorate targeted testing in New York City. Specifically, we're going to be making the STD clinics do something very different. I'm going to leave that for toward the end of the talk so I can show you the whole picture. But we're going to make them destination clinics, venues where people want to actually come to do this work. And we're also going to be enhancing what we're doing with our field services unit. So there are people who go out if you have a new diagnosis and actually interview clients, interview people newly diagnosed, try to find their partners, et cetera. We are soon going to be overlapping that with molecular data. So we're going to be finding the newly diagnosed person, sequencing their virus, comparing it to sequences that we have, and then working to find people who are not virally suppressed, who are in that cluster, to try to get them to care. So New York City is going to throw their hat into a different universe of epidemiology. It's very exciting. That will also mean that ultimately we will be doing a lot of resistance testing for the city, so stay tuned for that one too. Supporting care. So this is, again, linking and retaining people and getting them on antiretroviral therapy because it's good for them and it's good for their partners. Here's our original care continuum in New York City. So for those of you who've seen one of these 1,000 times, I'll just go really quickly. We look at the number of people we think have HIV. We use our old serosurvey to figure out what percentage are likely diagnosed. So again, we're working on this number with the 5-borough serosurvey to get a better sense. Then we look at linkage, retention, people who have been started on antiretroviral therapy, and who's been suppressed to viral loads less than 200. So you'll see that there's drop-offs, the most significant being in retention. So that definitely sort of triggers a conversation about how do we keep people into care. Because once you get them into care and you start them on antiretroviral therapy, many of them are suppressed. So it's really getting them there and keeping them there, which is key, because you all are doing a very, very wonderful job in New York City to maintain people suppressed and healthy. One of the things as part of the epidemic that we're working on is making sure that our data are clean. So when you see this slide, it actually estimates about 137,000 people living in New York City with HIV. So we actually think that that may be wrong. So what we did is use a probabilistic estimate. We did another analysis of the data to take a look at who may actually physically be in the city still, not just someone who we've diagnosed and are sort of following without good data or without complete data. And what we find is, let me toggle back, if you were looking, the number didn't appear here, but it's about 43% are supposed to be virologically suppressed on our initial continuum of care. When you clean it up, it ends up that about 64% of people living with HIV in New York are probably virally suppressed. What does that mean for ending the epidemic? We thought we had to go from fair to good, and it ends up that we have to go from good to excellent. And so 64% is pretty darn great. And so our goal really needs to be to get higher and higher. And so there's a lot of work to be done, and you can see that there are definitely spots that are doing better than others. So Manhattan is in the lead. We have Queens and Staten Island and Brooklyn all up there, and we're working with all of these jurisdictions separately to see if we can improve this viral load suppression number, and we're doing it in tandem with the state because they've been really good about looking at the quality of care and retention throughout the state and the city. So this is my favorite slide of all of our surveillance data, just to show you that New York City can make a change and make it happen fast. So these data demonstrate the time to viral suppression after someone is newly diagnosed with HIV in New York City. And it looks back at 2008, and then it goes forward to 2013. The pale blue bar represents viral suppression by 6 months after new diagnosis. By 12 months is the darker blue bar. So what you'll see is a straight line up. So right here, you can see that between 2008 and 2013, we have nearly doubled the percentage, the proportion of people newly diagnosed with HIV who are virally suppressed within a year of diagnosis. So when we say that New York can bend the curve, we see actively you are bending it every day. This is not a subtle trend. The trend continues up. The rate of increase is not declining. It is getting bigger and bigger. More and more people are achieving viral load suppression faster and faster. It's really a remarkable finding. So 64% by 12 months as of 2013. We are just skimming 70 when you look at 2014 data. So it's going pretty great. One of the ways that we're going to work to make this even better is through our care continuum dashboards. So facilities, about 47 of them throughout the city for the last several years, have received data from us called a care continuum dashboard that tells them about their linkage to care rate as well as their viral load suppression rate. So it's something that's been whispered in their ears via emails to their medical directors and to their administrative directors. But we're going to change that a bit. In New York, if you're a cardiac surgeon, they publish your mortality data online. So we're going to be publishing clinics' viral load suppression data on our publicly facing website. It's coming out for the first time December 1st. We're only doing our first 21 facilities that got these dashboards to begin with, and the goal is eventually to roll out to about 47 plus, which will represent over 70% of people living with HIV in New York City. Pretty remarkable. Why should this make you nervous? No. People are doing great who are in care. There are places where they're not, but for the most part, it's really, really fantastic news. So we're releasing the 21 sites, and this is a beta version of what it looks like. There will be a donut that will show people the number of patients we think you have in clinic. We give a whole story of how our numbers may be a little bit different than yours, given the way that we calculate them. Pale means virally unsuppressed, dark means virally suppressed. We will show a viral load suppression rate based on your facility. We will also show a comparator to New York City, and we'll show the direction that you've gone over time. The arrows are all up for the most part. So it's really good news. And some of them are in double digits. It's going to be a great release, I think. So you will also see yourselves up next to your colleagues. So this is actually the real live viral load suppression data that will go live December 1st. This is not beta. We've just masked the facilities so you don't know who's who. And what you'll see is there's a red line that's our goal of 85% viral load suppression. Please note how many clinics have crossed that line. It is remarkable. We've also added another little thing, which I think is going to be an interesting conversation to see what you all think about it, is we've done something which I haven't shown up here, but if you see the little teeny writing, it says transmission threshold. And so what we did is we also analyzed the data using 1,500 viral load as a cutoff based on some data about what a transmission threshold is like for viral load suppression. Very unlikely to transmit viral load less than 1,500. I showed it for two reasons. One, I want to show that there's some prevention element to treatment just to make the point that that's a piece of the story. The second point is some clinics that are down here below the red line have a lot of people who are in that less than 1,500 range, really demonstrating that there is significant effort trying to get them virally suppressed. So I think it'll be a really interesting release. I'm looking forward to seeing and hearing what people say, but more and more of it to come, transparency being important in quality. And so there they are again. In addition to releasing that, we've also hired Bisrat Abraham, who is someone who will work in my bureau, whose job it is to interact with the state and with facilities to get New York City deeper into the story of quality care in the city. So we will be the adapters of New York State AIDS Institute and the HIV-Qual program into the New York City clinics, and we will be a continuous force that will also integrate with DSRIP and really try to make quality a part of that story and have the city and state work closely together. So it's really all about using these dashboards to push care to a higher level, again, from good to excellent, because what you'll see is we're going to have to change all of our thresholds. We are hitting our goal, so we're going to have to move everything up. And so obviously I'm not going to give you an easy goal. I'm going to give you a hard goal. So we're going to give you as much support as we can to make it happen. Along with the care dashboards, we've also released the care status reports. Many of you have not used them yet. You may not be fully aware of them, but you will know more and more about them. They actually launched in spring 2015. So thanks to a great change in New York State law, we are able to use surveillance data to support care. What that means is, the way that we've interpreted that is that we've created an online secure system where if you have someone that you haven't seen at this point for a year and you're worried about where they are, you're able to query their name in the system. It goes to my Epi branch. The Epi branch looks at the registry, and they'll get back to you and say, follow-up is needed for this patient, no follow-up is needed, or they're deceased. So you can learn about what's going on with the patient. That's exciting. Why is it annoying? One patient at a time. What's coming in version 2? Rosters. So once we figured out that it works, and it does, we're going to be able to take clinic rosters and get back to you and say, these are the 30 you have to follow up on, these are the 20 who are taken care of somewhere else, and these are the 10 who have passed away. Hopefully 2 that have passed away. But that should be very helpful. More to come on that. But as we get deeper and deeper into this, the line between surveillance and care is going to become blurrier and blurrier, so care can be supported better by the data that we have. So we have a lot of things in store for New York City from the perspective of linkage retention and viral load suppression. We're working currently with Housing Works to launch a scalable citywide viral load support program that lives in the context of DSRIP called Undetectables, which is a strategy to really help support clinics do better. A piece of that may actually also include incentives for viral load suppression in some circumstances. So it'll be very exciting. We're going to use phylogenetics to link patients with viremia to HIV care. It's that molecular epidemiology. We're going to use that to find people not suppressed and work really hard with them on their terms to bring them to services. And I've already talked about the fact that we are putting our hat deeply in the ring of quality of care by introducing a new sub-piece of my bureau that will work with New York State and with our surveillance data to try to get clinics, again, from good to excellent. And now we've landed on PrEP. So that is the third pillar of the governor's plan. So this is our old campaign that was launched on the same day, actually, the governor made his announcement about the 3 pillars. So exactly on the same day, we launched these social media postings, pamphlets, et cetera. You may have seen them. You may even have some of these in clinic. You may be complaining to me because they've sold out. Yes, we're printing more. Don't worry, they're coming. But I'm very excited they sold out. But I stop here for 1 second and point at this one. This one was how we launched our PrEP social marketing campaign. We put it up on a lot of the Department of Health social media, and to date, it is the most popular post in the history of Department of Health social media. So people are interested and are watching. So I show you this because now it's old, and I'm going to give you at the end a teaser for what's coming on December 1st. One of my important strategies is that the message of PrEP and the message of treatment are about the same. So we should be clumpers, not people who create more silos. So you're going to see a whole new HIV sort of neutral approach to marketing. It's coming, and you're going to see a little preview at the end in the form of a 1-minute teaser video. So we did a lot of direct-to-client marketing, direct-to-patient marketing, but we also did a lot of marketing directly to clinics. So who remembers when drug reps used to come to clinic, right? They don't really come that much anymore. So all these drug reps need a job, and so we hired them. And so what we did is we used those drug reps to distribute our PrEP action toolkit to providers throughout the city. We did a couple of phases, and we visited about 1,400 providers at 600 facilities. This picture is my favorite. It is from the Stapleton STD clinic in Staten Island. I just surprised them there with a visit one day because I go to Staten Island all the time. And lo and behold, they said, your people already came. We're reading this now. And I was like, great, good. And so it's exciting that people actually used it. So we did a phase 1. Phase 1 was based on Epi. So we used incident HIV diagnoses and new syphilis diagnoses to target the clinics where we visited. Seemed to make sense. So we went out there and met people, and we found that after meeting with them, people were more likely to talk about PrEP from 25 to 34%. And in these clinics, with the right population for pre-exposure prophylaxis, we saw a statistically significant increase in PrEP prescriptions. Phase 2, we did not just the ones that epidemiologically made sense, but also the ones that sort of conceptually made sense, like places that did fertility management, people that were doing, who were doing contraception, other school health, things that seemed to make sense, even though they didn't seem epidemiologically to have a really slam dunk. And so what we found there when we went is that people were more likely to talk about PrEP from 25 to 39%. They were less likely to be completely wrong about its efficacy, so they got better at fidelity in terms of the intervention. And we noticed that they didn't increase PrEP prescribing, which may be because they don't have really that population. Nevertheless, something happened by visiting them. And then this is what happened in the city. So we have something that before I got to the Department of Health was called the High-Risk Behavioral Survey. That name has been erased. It's now called the Sexual Health Survey because that's really what it focuses on. And we have a couple different flavors. I'm showing you the data from the MSM piece of the survey. Soon I will show you data from the Women of Color piece of the survey, but this is just the MSM data. So we asked the question on the survey, both online and in person, do you know what pre-exposure prophylaxis is? And you can see that, again, just like my other line, it's straight up. And so you'll see that we went from low levels of awareness to now approaching 90% of our sample are aware of pre-exposure prophylaxis. So one of my important punchlines here is that it's really nice that people know about it, but now what do we have to do to actually get them to do it if they need it? Realizing that that entire bar of 86%, not everybody there needs to be on PrEP potentially. But how can we actually take this from knowledge to implementation? So then this is actually that same survey, and it's the data around PrEP utilization. And so you'll see that we were hugging zero pretty well for a long time. This is long in the HIV world, not long in anyone else's world. This is rapid in every other medical intervention. But you'll see that really starting in fall 2014, we saw a little wiggle, and then that wiggle doubled in spring 2015. So we're seeing that this trend continues. More and more people are going on pre-exposure prophylaxis using what we have from our surveillance perspective. And then this is another way to look at it. We participate in something that the Department of Health has something called the Primary Care Information Project. Providers that use eClinicalWorks, footnote, that's not you, so that use a specific EMR, they report data to us, and we're able to analyze it through their EMR, direct link. We looked at their EMR data to see how much PrEP was being prescribed. And then we looked at it in Chelsea and the Village versus other New York City and also all across the city. So the logarithmic scale says that PrEP is increasing across the entire city. That's great news. But look at what happened in Chelsea and the Village. Well, that's something. that doesn't tell you where the patient's from. It just tells you where the prescription was written. So if people are going to the Chelsea in the Village as a hub for LGBT health, we can scoot that up to Hell's Kitchen, you guys. If we can sort of look at that from that perspective, then this is success that we're seeing us play up. A couple of little secrets. Cal and Lord, they've reported publicly that they have about 1,500 people on PrEP. They don't use eClinicalWorks. They're not even counted in this. So this is just the eClinicalWorks providers. So we're seeing an explosion of PrEP, at least in some venues. And one of our challenges in New York City from the Department of Health perspective is that I need to take this orangey line and pull it up as well. So the rest of New York City has to come into this fold, and we're doing a lot of work to try to make that happen. So this is what our famous heat map looks like for PrEP. So you'll see there is an epicenter. You are sort of sitting near it, if not in it, for pre-exposure prophylaxis. And so now the trick is going to be to get these blushes of color that are lighting up throughout other parts of the city to get brighter and brighter. And our most recent success is we've gotten 2 sites on Staten Island to go on par with PrEP app, which that's kind of unheard of, that we have Staten Island sites that are interested in starting pre-exposure prophylaxis. That's really exciting. So how are we going to try to make this happen? So we expect that soon we will have what we're calling pre-exposure prophylaxis triads. So the triad means that we leverage different kinds of providers into one team. So we're going to have New York City supported testing sites, New York City supported CBOs, and New York City supported PEP and PrEP clinics who have to work together. So if you see someone in the testing site who's at risk for HIV, there'll be a clear mechanism of referral into either the CBO or the clinic. Same at the CBO. You see someone at risk, you've got a place to send them for testing if you don't do it, and a place to send them for HIV preventative care. There's something over here that I'm going to be revealing to you briefly, which is that another significant way in the door will be our STD clinics. I will be presenting this one-stop model to you briefly at the end, but the goal is to make those delivery systems into HIV treatment and prevention. I'm going to show you how we're doing it. Ultimately, when you get people into this triad, one way or another, the goal is to get them somewhere where they can get some kind of insurance, some kind of third payer, so they can actually live happily and healthily in primary care. And that primary care may include PrEP services. So that is the vision of how we want the convection currents of people on PrEP to work in the city, and I think we're pretty close to be able to launch that. So, the STD clinic. We have heard a lot about STD clinics in New York City being closed for renovation. It is true. There is one clinic that is closed for renovation, but every single clinic is having its mission renovated right now as we speak. And it's through this idea called the New York City one-stop model. And it really is about HIV and STD working together to make those clinics gateways for HIV treatment and prevention. So here's the strategy. We have a service check. People have come into the STD clinic and we find out what entitlements do they qualify for. Are they PrEP candidates? Are they candidates for ADAP, Medicaid, some other private insurance, an ACA plan, something? What do they qualify for? They get evaluated from the biomedical perspective. Do they have HIV? Do they have risk for HIV? Do they have new syphilis or a rectal sexually transmitted infection? Well, or do they need PEP? So what's going to happen is it won't just be an evaluation. What they need, they're going to start right there. I'll talk about that in a moment. And then there's navigation. So once we have all of this put together, they're going to get navigated to you, either through our PrEP network or directly to you through our navigators. They're going to land at your doorstep, and if everything goes well, they will have their insurance at least pending if they qualify for insurance. They will potentially be started on PrEP or antiretroviral therapy if they've been newly diagnosed. Please note I didn't say anything about PEP, because PEP is going to expand to 28 days in the STD clinic fairly shortly. You will still see some PEP patients who have insurance, but that's going to be their preference. They will have the option of staying with us the entire time for PEP. So the goal is to support and optimize, screen and start interventions, and link and retain. So this very busy slide is just here as a place marker to show you what the planning is for what we're going to be doing in New York City. Is it going to launch tomorrow? No. Is it going to launch in bits and pieces? Yes. So PEP, going to 28 days, people will be able to stay there. PrEP, we're going to get them entitled, and if everything goes as planned, they will have PrEP starter packs, 1 month's worth of medicines that will give us enough time to get them into some other payer and just enough time to land them at your doorstep. So hopefully they land started. And new HIV diagnoses. So you'll know that San Francisco has something that they call rapid. One Stop actually is rapid for everything, not just for people living with HIV. We're actually doing everything the same way, which is if someone needs an intervention, we're going to offer it to them. And I expect that we're going to actually be able to give you a plan on antiretroviral therapy starting for newly diagnosed in the STD clinic fairly soon, maybe even around December 1st. So it's pretty good news. So we're going to be able to really leverage those STD clinics to make them the inlet to you, so you can get all of these folks and give them the high quality care that you're so good at doing. So let's talk a little bit about something that underlies all of the pillars, which are priority populations. So these are really the consumers of HIV prevention and treatment, the people that we really want to like our product, which is really what we're selling around here. We know that stigma, bias, and health disparity are really the root causes of HIV. So I want to take a little moment to take a little detour out of the pillars to talk a little bit about what we're doing with these folks. So you may know that we launched an LGBTQ coalition of organizations. Some are HIV providers of service, some are LGBTQ providers of service. They've never really talked together so much. So what we did is we brought them together at 2 summits. We got a dating profile on them, and then we speed dated them. And now they're having meetings with a very interesting combination of bedfellows to come up with a plan, to come up with small projects that we can then use private funders to support. So this is going really well, and we have had them sign a pledge that they're going to stay engaged in ending the epidemic by working with their partners. We have 70 of these people, 70 partners. So again, that's like that's all of San Francisco. So we have all of them all in one story, and it's really exciting. A lot of really good plans are happening. We're also working on generating an LGBTQ healthcare Bill of Rights. It's not just going to be a static document. We've actually already had, I think it's 12 focus groups of consumers as well as providers. We're going to create this document, put it online, and you'll be able to click on what the right is with a list of resources. So for instance, you have the right to high quality care related to HPV. Click. This is where you can get vaccines. This is where you can get an anal pap. This is where you can get a cervical pap. So it's going to be a real resource, not just a list. We also have been working with our city health information bulletins to get the word out with continuing medical education attached to teach people how to make their clinics better for trans people and people and MSM, since we think that one of the barriers is that clinics are scary and people come and they get mispronounced or they just don't feel right. And so we really are working with clinics that have a lower level of understanding of this than all of the Mount Sinai universe of clinics to try to make things better. We're also, we've released a transgender women's guide, and we are soon to release our transgender men's guide, which will make us, I think, the first in the country to have a trans men's guide. It's very exciting. It's good news. I can't show you the cover yet because it's still getting finished, but it's coming very soon. And so ultimately, I make the plug that when we look at the story of HIV treatment, at the story of HIV prevention, and the goals of ending the epidemic, a couple of things become pretty clear. We know that treatment is treatment. It works. People don't die. They don't get sick. We know treatment is prevention. They don't transmit if they're treated. And now it looks like prevention is at least partially treatment. So for some people, being engaged in medical care may mean that it prevents HIV acquisition. And so ultimately, the story is kind of the same for everybody. So rather than polarizing our story, it's important for us to become status neutral. This is our normal continuum of care that I just showed you, and I'm advocating for a new continuum that takes into account people at risk for HIV infection as well, and really brings us to a place where we can identify the care of our priority populations really as the care of people rather than the care of a status. So I think it's going to be really important that we evolve our thinking to really go with what the science and the advocates are telling us. That's just a little bonus. So, we have an upcoming social marketing campaign. It's called Play Sure. I'm going to be showing you something about it in a moment, but a couple of things to highlight. We previewed it at Pride. Our first little peek at that was using a little pamphlet that we handed out. The pamphlet is not for negative people, it's not for positive people, it's for both. It talks about being sure and playing safe. It talks about both HIV treatment and condoms and PrEP in one story, because we're going to try to lump them together into one tale rather than split them into statuses. A couple of important things that happened in the context of this. New York City, for the first time ever, has said that it's okay to enjoy sex. I know that sounds weird, but here it is. That's the debut of you can enjoy your sex life. You'll see in a moment that we're going to go with that. And we're also going with the idea that it's important to teach people that there's a whole toolbox of how you can prevent HIV, and you have to use all of it and not just part of it. So we have other things coming. We're going to be doing a new look at mortality in New York City. I can't tell you more about it yet, but maybe you should go to Croy. We're going to be creating a more nuanced message for prevention. I definitely didn't show this today, but December 1st, a prevention device that I created that came out of, drumroll please, Jack Martin Clinic will be released on World AIDS Day. One of my patients brought me something. I took a picture of it, and now it's an industrial designer made one for New York. So it's going to be a new prevention device that you're going to be able to distribute to your patients, both for prevention and for treatment. And we're going to try to make all of this way more appealing to potential consumers of this product, which leads me to my preview before I open for questions. So on World AIDS Day, we're going to launch a new campaign, and this is its preview. It's not the campaign, just the preview. Let's do it again. So as you can see, we're trying to do a fear-based strategy. Just kidding. So we're really trying to make this a lot more appealing. A couple of things about this preview that are maybe lost to many of you in the audience is that many of the people that you're seeing are trans. I don't care that you don't know that. But when we put trans men and trans women on the subway, we're giving a very clear message to one of our priority populations. So you will be hearing their voices, you will be seeing them. The next phase of this is going to be a real social media commercial, not just people dancing and looking like they're having a nice time, but about HIV treatment and HIV prevention. So take a look. Watch out for it, World AIDS Day.
Great. Thank you very much.